we need multimodality treatment to reduce the chances of recurrence as much as possible. So yes, with use of only surgery, the overall survival is to the tune of 23% for non-organ confined disease, with organ confined disease to the tune of 50%. So yes, a significant number of patients will recur in a short time, with that in around 1 year to 2 years. So let's start with a case. A patient of 53-year male presented with painless hematuria. Routine labs at the baseline showed hemoglobin 8.5 and creat of 4.5. Requesting Dr. Lalit to highlight how our residents should evaluate the case and what should be the further steps to evaluate this patient.
Increased creatinine. It's a male patient that differential diagnoses are like carcinoma urinary bladder. There can also be possibility of CA prostate also. So we have to take detailed history of lower urinary tract symptoms as well as advanced and metastatic symptoms. Then we have to do the abdominal examination as well as digital rectal examination, genitalia examination. We have to look for the prostate, whether it's hard, what is the size of the prostate, about the meatus. Prostate is free from the pelvic wall, its mobility of the mucosa over the prostate. So these all things we have to assess. After that, we have to advise for the investigation. Specific investigations are like ultrasound abdomen with PVR, that is post-void residual urine volume. We have to look for the kidney, whether there is hydronephrosis. We have to also rule out the malignancy of the kidney. Though usually, as there is increased creatinine, lower tract pathologies are more common. So, other than that, all routine investigation as respect to the CBC, RFT, LFT, blood sugar, urine routine culture. If there is suspicion of urothelial malignancy on the ultrasound, then we have to go for further investigations like plain CT scan, KUB, along with viral markers, PSA. These things we need to do.
Thank you. So these were the basic investigations. There were actually, we can see there were multiple masses with bilateral hydronephrosis. So this is very clear that this patient is having hydronephrosis bilateral, and this is due to the central lesion which is there in the bladder with its causing obstruction. Now, Dr. Shashank, I would like you to highlight what should we do now in such patients.
Due to the high volume at our center, this is a typical middle-aged male with anemia, looks like a CKD picture. Not sure, before seeing the scan, we're not sure whether it's actually CKD or this is obstructed uropathy. So for the residents, I don't know how many people are available, these patients should be taken seriously at the outset, at the emergency. Because these patients we have seen frequently will be present with severe dyslipidemia. Their sodium will be very low. Usually this patient present with potassium of around 6, above 6, just in danger of getting a cardiac event. And plus these patients are at a very high risk, and some patients are actually in urosepsis. We frequently admit these patients. So that should be in the mind. As a surgeon, my first goal is to stabilize the patient, look at the electrolytes, ABG, stabilize the patient, get the ABG done, acidosis, we should manage the acidosis, give a drainage to the urine. It can first way will be through the Foley's, start a IV shot of antibiotics, see the TLCs, and if required, a nephrostomy as soon as the creat comes down, or after 1 or 2 sessions of dialysis. And I think the patient should be good to go for further evaluation.
Okay. So I would like to take comment of our
UJ. So it gives us a clue that this obstructive tumor is either invading, as sir told in the previous, like either it is an indirect evidence of muscle invasive. Here there is no doubt that it is a T3 disease, or it is the covering the ureteral orifice. Both the cases, Foley's won't help. Ultrasound gives us a clue that there is moderate to gross hydronephrosis. The only issue is because of the high creatinine, these patients usually have bleeding parameters are deranged. They might have low platelet, INR deranged. So just 1 or 2 sessions of dialysis, and then we can go intervention, like put a PCM in. So hydronephrosis gives us a clue, plus with the deranged electrolytes, raised creatinine.
So basically, right on this, we can go to the previous slide. So when hemoglobin was 8.5 and creatinine was 4.5, there are other causes of having high creatinine. So like Shashank has mentioned, urosepsis, this could have been a cause. If we look at the CT scan, the parenchymal thickness is very good. There is a moderate hydronephrosis, so if patient is not having any diabetes or hypertension or any other comorbidities, so likelihood of having medical renal disease is quite low. So usually this is a means the high creatinine is because of the surgical cause. So looking at all these parameters, so we need to act fast. That so hemoglobin is 8.5. It may be it might be low in case of CKD.
Yeah.
So patients usually these patients maintain a hemoglobin level of 7 to 8. So 8.5 hemoglobin could be because of the CKD, could be because of this hematuria as well. So looking at this picture, the patient most probably is having obstructive uropathy.
So
Then again, to answer your question, if urine is good, police dala or urine आ रहा है अच्छे से, so that is again there are two causes. One is bladder outlet obstruction, and then another is this ureteric obstruction. So bladder outlet obstruction can lead to hydronephrosis, and ureteric orifices obstruction again can lead to the hydronephrosis. So usually what happens, bladder outlet obstruction leads to bilateral, and if we look, this is a huge tumor, most probably covering involving or covering both of the ureteric orifices. Usually, majority of the patients, the hydronephrosis is present on a single side. So unless it is a bilateral hydronephrosis. Usually, unless it's a unless it's a bilateral hydronephrosis, the usually cause of the unilateral hydronephrosis in the case of renal mass is basically, in the bladder mass is because of that tumor. So bilateral hydronephrosis may be because of, I am not able to differentiate whether this is a large prostate as well, or so it could be because of the prostatic enlargement as well. So all these things should be kept in mind and discussed if required. Say for example, because of urosepsis, patient might have increased serum creatinine as well. So,
Just I want to clear this point. As the NCCT scan has showed the bladder mass, so we have cause of bladder outlet obstruction. If there not have been bladder mass, then we have to give a trial of Foley's catheter. In this patient also we can give trial of Foley's catheter for like 7 days, 3 days, 5 days. Then we can follow the trend of the creatinine. If it's decreasing, then we have to keep on the Foley's catheter, that is indwelling Foley's catheter. Then we can wait for disease stunting or PCN. Usually disease stent are not put in the urothelial disease, and PCN obviously we can put in this patient. Other causes of bladder outlet obstruction, this is not a case of bladder cancer, there can be neurogenic bladder, prostate disease, urethra. Go for creatinine 1 or 2 days after, 3 days after. If not decreasing, put PCN directly.
So, Dr. Pooja, what is the
because then the procedure itself will be more damaging than beneficial. So that is why we do a check ultrasound and check for in pyelonephritis component, and we need to know whether the dilated system is present or not. Undilated systems, it is very difficult sometimes it is difficult to get proper access. A good dilated system is easier to do PCN. In this case, we can easily put a PCN here.
So in such case, PCN and 2 weeks came down to 1.1. So that is the situation Dr. Pooja has also highlighted in this talk. I will take comment from Dr. Vipnesh. In such situation, when creat has come down to the patient is the creatinine is normalized and that there are no other factors, and definitely can consider. Okay, thank you. So moving further, after when hydronephrosis has resolved, otherwise DTP-GFR will give erroneous. So yes, DTP-GFR can be
before proceeding with PCN and other things.
No, before proceeding with PCN, it is not. It will not be helpful because Dr. Manikandan, you can highlight the problem in such.
Because before doing PCN, if you do a DTP-GFR, it might erroneously give a positive low GFR because of obstruction.
Creatinine is 4.5 and DTP is not a value. Creatinine rises.
So better to do a DTP-GFR once the obstruction is relieved, to get a ideal GFR. Right. So yes, after stabilization, when GFR is seems that urine drainage is good, USG shows that hydronephrosis is resolved, definitely DTP can be considered if the GFR, eGFR is coming to be the borderline in such cases. So which anesthetic to choose, this has been discussed, so I'm not taking in detail. DDMVAC seems to be somewhat better options in fit patients, so that can be considered. This is the trial which has shown improved PATH-CR rates, and 3-year PFS rate is also much better, around 10%. When to offer bladder preservation approach? So now the ball goes into the court of our radiation oncology team, and I request Dr. Prashant to take this. Who are the ideal patients which you would like to see before deciding?
Yeah, so it should be less than T3 disease. So in this case, all practical purposes, likely that extravesical spread is present.
Yeah, not in this case.
And second is, the patient should not have hydronephrosis, ideally. And patients should not have diffuse CIS when a cystoscopy and a biopsy is taken. So if these three things are absent, and initially has good bladder function, capacity should be present, and concurrent chemo they should be able to receive.
So these are some important points. Number one, which I think is important, is urothelial histology, because all the bladder preservation approach is for urothelial cancers and not other cancers. So if patient is having squamous cancer, definitely we will not have confident in utilizing bladder preservation approach, though the role of adjuvant radiation will come there because of the squamous histology. T2 to T3A is ideal. After T3A, definitely it is very difficult to offer CT-RT based preservation. No diffuse CIS, no hydronephrosis, unifocal tumor, which are less than 6 centimeter in maximum diameter, good bladder. So if bladder is already not functioning well, it is not worth to be preserved. So it can be foregone. Fit to receive